तो समझ में यूज कर सकते हैं।
Mute.
Arjit, you're mute.
I'm mute? No.
No, we can hear you.
We can hear you, but we can hear someone behind you also.
No, not. There's nobody here.
No, Arjit. Yeah. Okay. Start.
Okay. So, what we are going to talk about today is. Oh, sorry. Did it go off?
No, it is there.
Huh?
It's there. We
Yeah,
can see it.
We can see.
You can see the screen?
Yes.
Yes.
Okay. Then it went off from my screen. Okay, just a minute. Let me get it back. Yeah. Okay. So what we are going to talk about today is this Ayushman Bharat digital mission, something which was started a few years back, and as of now is something which is now moving towards uh, adoption by just about all the hospitals. And I'll basically start with saying this, that just a minute. Wow. Okay. Yeah. So, what exactly is this ABDM, Ayushman Bharat Digital Mission? So, the idea basically is that today you have your health records, which are largely in paper-based format, and we want to make this digital. You have to make it more efficient, accessible, and safely transfer data across the health ecosystem. And when I say health ecosystem, this includes hospitals, clinics, labs, pharmacies, even the ambulances, etc. And therefore, what we are trying to do basically is that the patients, doctors, and everybody who is connected with the health ecosystem are connected with each other and can access the data in a secure manner. One of the things which happened was that the success of UPI has been what has driven the government to work towards making things a lot more connected. And then they have put in now a whole lot of organizations from the government side. The National Health Authority, the National Health Claims Exchange, which is NHCX. Then there is a National Resource Center for EHR, and then there is the National Accreditation Board for Hospitals. Now, each one of these is a specialized agency in their own right, and they are basically acting as a part of the or taking up the parts of the system which are relevant to them. The National Health Authority is, of course, the one which is the regulator for everything. And the whole idea is, of course, it's a digital network that you're trying to create across the system. And there, to be very frank with you, there isn't anything like this on this scale anywhere in the world. Some of you might think of or if you are aware of the UK system called Spine, which enables transfer of data across the system between various hospitals, organizations which are there as a part of it. But this is a centralized system which is owned by the government. And the entire health system there is owned by the government. So that, but whereas here in India, we have as much as there are government agencies providing health services, you have a large number of private hospitals as well and private organizations. The diagnostic part also is something which is largely some okay, the largely something which is privatized. So now let's look at these two major components. One is the Ayushman Bharat Digital Mission, which is basically looking at transferring health data across the ecosystem. Arjit, can you mute yourself? I think there's a background noise. Yeah, thank you.
Talwar, mute your system, yeah.
Okay. So the Ayushman Bharat Digital Mission is basically to first of all digitize the records that you have, and then currently you have it in the form of physical files, which is hard copies. There is a loss of data. There is damage to the data. It's not transferable. It is accessibility is the problem. Sometimes hospitals also have a separate medical records department which keeps this data, and finding your health data from that is quite a challenge even now. The other part of it is that each hospital and each organization within this health ecosystem seems to have a system of their own. They don't have a mechanism by which there is any kind of standardization. And that is one of the major things that one is trying to address here, by which it will be possible to standardize the content, standardize the structure, and standardize the mechanism by which data is can be transferred. Now, because these are paper-based records, finding data takes time, and there can be a long wait time for doing this as well. Plus, even answering something like a question like, which is the hospital nearest to me, which has a bed available for a particular specialty, is not something which you can answer in a simple manner. You probably will need to call something like 15, 20 hospitals before you can get a straight answer to that. The important part is that it isn't data driven. So take a very simple thing like just about 2 months, not two, about 4 months back, the Insurance Regulatory Authority came out with this concept that whenever a claim is raised by a hospital on the insurance company, the insurance company is supposed to respond to it within 3 hours. Now, what is the mechanism really to monitor something like this? Except that you ask the hospitals to say whether they got an answer within 3 hours, or maybe ask the insurance companies to say whether they have responded within 3 hours. There is no mechanism really available for ensuring that you get a data in a manner which is not biased. So one answer to that is, of course, ABDM. The other one is the NHCX. The National Health Claims Exchange basically is about making the claims on the payer. And when I say payers, this includes insurance companies, some of the health schemes like ESIC, Central Government Health Scheme, the PMJY, which is a big scheme under this. And then since health is a state subject under the Constitution, each state has its own schemes. And I'll come to that a little later on. which basically, so they have a kind of liberty to decide who is eligible and who is not eligible as well. Most of them would add to whatever PMJY is allowing you, and that's how it works really. Now, the standardization that has been done both under ABDM as well as under NHCX is to use some international standards. ICD-10 for disease classification. I can tell you my personal experience on this was that we implemented this as a part of a hospital information system and electronic medical records for a company in the Middle East way back in 2005. And even today, there are several hospitals who have probably not even heard of this. And except for something like the death, cause of death record, which they provide to the patient in case of a death, they don't use ICD-10. For whatever has happened to the patient, for whatever reason he has been admitted to the hospital, or even if some treatment is being done, ICD-10 is not being used. The next one, of course, is the procedures that are carried out. And then if you look at this, I have come across hospitals which mention that procedure in one or two words. And then there are hospitals which will mention the same procedure in a whole sentence. So, so analyzing anything of this and to get the other side who is going to take a look at your record to understand what you're trying to say becomes really complex. And there's no standardization there. So SNOMED CT is again international standard. ICHI is something which is WHO standard, international classification of health interventions, and SNOMED is standardized nomenclature for medical in medicine. So these standards are now being used as a part of the National Health Claims Exchange as well as ABDM. LOINC, which is basically being used for observations, identifiers, names, and codes. That's what it stands for: logical observation, identifiers, names, and codes. This is again an international standard where, say, laboratory results, even observations like your blood pressure, etc., even height and weight for that matter. There is a standard, there is a codification which is available. So by which, so worldwide it will be known by exactly the same way. The moment you use a LOINC code associated with that observation. The CDCI is something which is specific to India. Common Drug Codes of India. Now, Common Drug Codes of India basically is something which is which has to be specific to India, basically because we have a lot of medicines which are combination medicines. This is not common across the world. Across the world, they will have individual components of those medicines being given as separate tablets or injections or whatever. We do have a combination which is being provided. DICOM has been one of the oldest standards, and rather surprisingly, it is something which has stood the test of time. And this is for all diagnostic images. So right from X-rays, CT scans, MRI, whatever you can think of, even ECGs are put under this standard. So this is a digital imaging and communication in medicine. So it was a standard developed by the radiology companies, frankly, so that data could be exchanged across. And then you have, so these are standards which are going to basically do something very specific, and that is to have the data codified in a certain manner or structured in a certain manner. But to transfer data across, you need a methodology and a data structure which is standardized. So whether it is take a very simple case like you are talking of a patient who is you are saying is a male and age say 40. Now, if you were to put this as male as M, or it is a complete word like male, or it is a symbol of the male. So there are various ways in which hospitals will show this on their system. But this is not something which may be understood at the other end. So a standardization of even for something like this, of course, FHIR, which is fast healthcare interoperability resources, which is it is standard primarily for healthcare, by which the data can be the data structures are defined, and so everyone uses the same mechanism. And once it is received at the other end, they would be able to decode it and use the data for understanding the patient's medical record. There are standardized APIs which are part of FHIR, which is application programming interfaces, by which you can search for data and you can interchange data as well. And then I'll come to the foundational components of ABDM in a minute, which is the next slide. So what exactly is it that is a requirement under ABDM? The basic minimum kind of stuff. So you have ABHA, which is a Ayushman Bharat health account. Now, once you say it is an account, it means that it is like a it's actually a 14-digit number which is linked to your Aadhaar. They also have a provision by which it can be linked to your driving license. But that was in the past. Now, I think almost about 98% of the data is now linked to only the Aadhaar. So it is a unique number, and each person will have a unique number. This 14-digit number. Most of you would probably have this number already. If you have taken your COVID vaccines from a hospital where they were already linked to the system, then they would have created this number for you. How you find it out? I'll come in the next slide. So the idea now is that every kind of medical record is attached, so to speak, to this 14-digit number. So whether you have gone to a hospital and a hospital has a lot of record about you, starting from the day you went to the hospital, even in your OPD, and then thereafter we were admitted, and a whole lot of tests, procedures, etc. were done on you. All that is finally linked to this 14-digit number. So the idea is basically you should be able to get a patient's record right from his cradle to grave. So whenever a patient's record is required, wherever it is in the health ecosystem, this can be captured and brought at one place. Now, it's not always necessary for all the kind of problems with which patients come to a hospital. But then there are other cases, like say, for example, you have cancer or you have, say, a cardiac problem. Then it is necessary to have data going back maybe several years. So it might be able to trace what actually has happened over this period of time. So the ABHA is a unique number for every citizen of India. Since it is connected to Aadhaar, so Aadhaar is normally it's for a resident. It is not for a citizen only. But now, if you have an Aadhaar, then you can have a ABHA number, and we'll see how that ABHA number is being used other than the health record as well. So these digital health records are connected with ABHA, and then every hospital in the country, every health facility. Now, when you say health facility, it is not limited to the hospitals. It can be clinics, it can be diagnostic centers, it can be even a pharmacy, or even an ambulance, let's say, or say an optometrist could be a part of. If there's an organization providing that service, then just a minute. I'll just take this call in a minute and get back. हॅलो. अरे मी आता मीटिंग मध्ये आहे, जरा एक अर्ध्या तासाने फोन करू शकता? हा, ओके. Sorry. So every such health facility needs a registration. As on today, also they register, but we are now standardizing this across the country, and it will be a standardized number which will be provided to every healthcare facility. And there is a record available of whenever you have any digital health record getting created, this health facility record also gets attached to it, which means you know that if this particular procedure was done, you know exactly where it was done. As much as there is a health professional registry also. Now, health professionals are doctors, nurses, pharmacists, even radiologists, radiographers, all of them. So the advantage in having this again is that, again, anything that you might have done, a diagnostic test for which even a blood sample has been collected by the person who came to your house and collected the sample, even his record would be there as a part of the health professional register. So the record basically is something which has all details about where was this done, which facility, who is the person who did this, at various stages in the whole process, and on whom it was done, which is the ABHA account. And then it is one thing to store this data as a digital data and to be able to exchange this data across the system. The simplest kind of situation is, let's say you have your medical records available in Mumbai, and so you have a file of that particular hospital, and you happen to be traveling to Delhi, and for some reason you need some kind of a say health intervention. In which case, one of the first things that the doctor is going to ask you is, do you have your medical history? And this is obviously not available because it's in a paper form. Whereas if it is digital, then this data can be transferred from wherever it is to that hospital based on a consent which you provide as a patient. So you own the record. This is one of the most fundamental aspects of the ABDM system, that the patient always owns the record. So even if the hospital has the data is actually owned by you. And then only when you provide a consent that it will be possible to transfer the data from one organization to another, which is what the consent, the health information exchange and the consent manager does. Now, how does this work really? So whenever there is a hospital which asks for this data, it will pass through the consent manager. The consent manager is going to send you an SMS, or if you have an app, then it will give you a notification on the app by which you are alerted that a consent is being asked for. So when the consent is being asked for, that time you would be able to say yes or no to that. Because if there's somebody randomly asking for data, then you can obviously say no. Whereas if you are in the hospital and you know that this hospital is asking for data, you should be transferring the data. So once that consent is given, then between the two hospitals, the data flows directly without going through any other route. All right. The other side of the system which is required, one is these registries that are there and consent manager, is whatever software is being provided for exchanging the data needs to have a certain amount of capability. So there are 4 milestones that they have mentioned, and there are, as of now, as far as I know, more than about 500 organizations which already have most of this available. One is to create capability to create the ABHA. So if you walk into a hospital and you don't have an ABHA ID, you have never created in your life, then you can go and check for it. You can create it. It can be for the hospital, it can be the insurance company, it can be the lab, wherever you go. The second thing is that that organization has the capability to transfer data out. So whenever there is a request which has come in from someone and a consent has been given for transferring the data, the hospital has the healthcare organization has a capability to transfer the data to whoever is asking for it. Now, once the data has been transferred to the other one, they should have the capability to receive it, decode it, and understand the data in a standardized, structured manner, which is milestone 3. And milestone 4 basically is for getting information about the healthcare facility as well as the healthcare professionals. So if you are asking for a doctor who is, say, an orthopedic specialist, then his health professional registry would have registered him as a orthopedics specialist. Or say, let's say, a hospital facility, and you want to find out which are the specialties available under that hospital, then you can find out using the milestone 4. I mentioned this, that ABHA is similar and actually linked to Aadhaar, and it's a 14-digit number. And if you have got a COVID vaccination done, now how do I find out what is my ABHA? So for this, you can download an app, ABHA app. It's available both on Android as well as on iOS. And the moment you enter your Aadhaar number, you should be able to find your ABHA number as well. If it's not there, you can create it through the same app. It can be through the app, it can be through a portal also. So both are available. There is an interesting concept by which there's something called ABHA addresses. So under each ABHA ID, you can have up to 6 different ABHA addresses. And you can store your data in each one of them separately. So let's say it's a mental health issue, and this is not something which is relevant when you are going to a hospital for getting treated for malaria. So you can as well have a general medical data. So that's a separate address. And you can have other separate addresses that are created. This is like creating different email IDs. And it actually has a format which is also similar. So you have some name or number at the beginning, and then at and followed by ABHA. Okay. So you can have your mental health data, your cancer data as kept as separate pieces of data in separate boxes, so to speak, and so under each one of the addresses. And you can, when you are sharing data, you also have the option to share only the specific data that you think or the hospital says this is important for us uh, for treating you. Okay, now how is this ABHA being used? So, as I said, it is like Aadhaar. So, by itself, it does nothing except that you are given a number. All right. But then you can attach it to a Ayushman Bharat registration. All those who are over 70 can get the benefit of this. You just need to register yourself on this. There is an Ayushman app which is also available. And under that, you can, if you give your ABHA ID, then it provides you something which is called as a family ID. Okay, and why family ID? Basically, because this benefit of 5 lakh rupees is something which is available to the family. It is not to an individual. So, over 70, and say you and your spouse are both over 70, then, or maybe even your parents are over 70. So, you can put all of them under that same family ID. And everyone gets covered for that 5 lakhs total per year. Okay. Additionally, this family ID can also be created for specific kind of persons, like the socio-economic caste census was carried out, and then there is a list available of all the persons as well as uh, the families. Then there is a separate category called PM Cares, which is for COVID orphans, children who lost their parents in COVID. So they are covered even if they belong to a family which is quite well off. So they are covered under PMJY. The central armed police forces like the BSF and Assam Rifles, etc. So those kind of organizations and their families are also covered under PMJY. Construction workers is one category which has been separately created. And so all construction workers are being covered by PMJY. And then there are members of ESIC, CGHS, etc., which is currently in the process of being added. And one would expect eventually that all these government schemes which are there will get covered under PMJY. Pradhan Mantri Jan Arogya Yojana. Okay, I didn't mention that before. Now, I mentioned that there is that healthcare is a state health is a state subject. So each state has its own schemes as well. Currently, the mechanism is that 60% of that whatever is required to be provided by way of financial assistance is provided by the central government and 40% by the state. So, for example, Maharashtra has a scheme which is known as Mahatma Jyotiba Phule Jan Arogya Yojana. Okay, and similar kind of schemes are there with other states also, yeah, under various names. Each state has its own system. Maharashtra, for example, now covers you for this 5 lakhs per family for all the above categories which I mentioned. And anyone who is a citizen, irrespective of whether you belong to this category or not, who is a citizen of Maharashtra, can be covered for 1.5 lakhs in cases of accident. So this is something which is very special to Maharashtra. This may or may not be available in other states. And one of the things that is therefore required in case of Maharashtra is that you need to have a ration card. Because that's one thing which they say that will prove that you are a citizen of Maharashtra or domicile of Maharashtra, so to speak. Okay. So that's how each state is doing things in their special way. So now let's look at who all are going to use this kind of ecosystem. So obviously the whole thing is designed for patients to make it simple for the patients to use it and to be able to use to be able to transfer this data across the ecosystem whenever they need. Rama, you raised a hand. I'll come back to you. This is about the last slide that I'm coming to. So I'll come back to you when we finish with this presentation. So hospitals and clinics, of course, which are going to be both the hospitals, clinics, the diagnostic centers, pharmacies, and all these service providers, as well as insurance companies. All of them are the stakeholders in this system. And they definitely are the ones who are beneficiaries of the data that is coming in. On the other side, you have standards organizations. For example, let's say one of the kind of issues that we have is that how many diabetic patients do we have in this country? Everybody says that India is the diabetic capital of the world. But really, how many patients do we have? We don't have data. And this kind of data is something which is required by these standards organizations, which will help them to understand what is really happening. Then, of course, the government health authorities. So whenever there is a disease outbreak, they should be alerted immediately. So they are major stakeholder in this, as well as imagine a data where you have for a particular disease 10,000 records available, and there are certain procedures that have been done, there are certain diagnostic tests which have been done, there are certain medicines which have been provided, and you know what is the outcome. So data like this is something which is crucial if it comes to medical education. Right. Research organizations will use a significant amount of this data, and the way this data is going to be transferred to these organizations is not the raw data, but anonymized data.
You, Rajiv, we have 15 minutes left. So you can see that after that also we can continue the session, but we'll stop the recording. And if the people want to ask questions to you, they can continue.
Okay. So just give me 2 minutes. I'll just finish with this slide.
Sure.
Okay. So there are research organizations, there are regulatory authorities, like for example, IRDA. I mentioned this in the beginning that how do they know whether the institutions which they are supposed to regulate, whether they are actually following the regulations or not. So based on the data which is available here, pharmaceutical companies will eventually have information like disease patterns across the geography as well as over time, etc. And then there are organizations which provide the various kinds of software like hospital information systems, laboratory information systems, picture archival systems, and telemedicine and electronic medical records. And then finally, you have the health record repositories. One of the questions regarding this was that what is a health locker? Now, the health locker is basically a health record repository where you will have data which is going to be available, where you can, as a patient, you can put in the data, as well as if you have captured the data from various sources wherever you were treated, then that data can also be made available in your health record repository. Just a quick understanding as to how things will change as a result of this. Like when a doctor prescribes you medicine, your pharmacy can pick up that medicine, the prescription, and have it delivered to you. Or the same thing with the diagnostic test. If they have ordered something, then your preferred laboratory can pick up that information. And with the patient consent, now it can be transferred back to the place which was treating you. The other part of it is that you can find hospitals with relevant facilities, healthcare professionals who are specialized in that particular area which you want, or you can find an ambulance, diagnostic centers. You can book a bed, you can book specific services like diagnostic services, and then share your records with the insurance companies for a better premium. I mean, you don't have certain disease issues. So obviously, it should not be that there's just one kind of pattern for everyone. So you can always negotiate a better deal with the insurance companies. And then lastly is that you will be able to track the status of an insurance claim that has been made, right from eligibility check to payment. The authorities can monitor the turnaround time, automate the claim adjudication. I'll come to this in the question answer session, as well as the turnaround time and claim rejection status. Standardization of procedures, etc., has been done by some organizations, some of the insurance companies, for example. And the schedule of charges also has been standardized. So how much should each service be charged? So this is currently something which is left to the hospital. So that will not happen. And of course, the portability of health data, which will happen. And then it acts as an early warning system for public health. Sorry that we have to sort of go through this rather quickly. And with that, I think as far as the presentation is concerned, I've come to the end of it. So something which I'll now come back to.
Rajiv, I think before people start asking questions, can you take 2 minutes to tell what actually you are doing? I mean, that is of interest to your friends here.
Yeah. Okay. So basically, I'm a part of a company which is providing, as on today, a national health claims exchange connectivity between the hospitals and the insurance companies. And I'm proud to say that we are the first to do this. Others are already doing it as a part of the paper-based record, not the NHCX route. And the whole idea is that this kind of a system can be used even by small hospitals which do not have the capability to put in that much of effort into their own software systems or don't have the means to put in that kind of money that is required. So they could use our system for getting the claims done. So this is one part of it. Now the next part of it, which is coming, which is the Ayushman Bharat, the medical record exchange, which is taking place. So that's coming then about 2 to 3 months down the line, and we should be there as well.
Rajiv, I think thanks a lot, and I think we'll get to know more about it. And it's interesting, and I think people have got a lot of questions, obviously. And what I like is this thread to continue in our WhatsApp group so that all the clarifications, doubts, concerns will be addressed. So what I will do is that I'm going to stop the recording now, and you people can continue the discussion. Because I have to.
So I have a few questions which I can see here. Ramarao says, can you explain the monetization of benefits also? What exactly do you mean by?
Yeah. I've actually got 3 questions. So I'll start with a simpler one. When you say a family has got that 5 lakh kind of per year, isn't that the government pays for 5 lakh of insurance or for 5 lakh costs of hospital or whatever medical treatments? That benefits, how is the benefits defined in your structure?
Yeah, so under the PMJY scheme, there are about 2,000 odd packages that they have defined. And it contains something which is like as simple as being, say, hospitalized for dehydration, all the way to knee replacement or a hip replacement or say stents being used on your heart, etc. So
Sure.
so the entire range of so it contains a whole range of services, as well as the diagnostic tests which are required. The entire not just the procedures, but his stay in the hospital, the medicines that are required, and everything that goes with it. So all that is covered under PMJY to the extent of 5 lakhs per year. If it exceeds that, then of course the patient might need to pay. But
Okay.
As of now, that's where it is. Okay.
Got it.
Next question.
Yeah. Next question is, when you look at the consenting process
Yeah.
and the health data exchange process,
Hmm.
is that done with a physical format, like an electronic format? I know it's not paper, but is it kind of like an electronic form that comes where people sign off, or is it like a text message? So how do we know we're consenting to what and where? Because
Okay.
that's critical.
So basically, what happens is that if you have a ABHA app, then it will come to you as a notification first, and then in the app you will have a place where you can say consent yes or
Got
no.
it.
Okay,
Got it.
that's
Got
one.
it.
Second thing is, okay, this is where you must have a smartphone. But then the significant population which is still using those old 2G phones. So
Right.
in their case, it will also be sent as a SMS
Got it.
to those people, and you respond to the SMS, and that's it.
And that's a good segue into my third question, which is, can you point me or can you send me how does the technical architecture look like for managing the cybersecurity and health exchange standards for it?
Yeah,
Or what is this, so, the
so
rough
yeah, so
architecture of
no,
how,
no,
where is it being stored? How is it being transferred? What are the standards used? How do you
yeah.
protect us from misuse?
Yeah, so basically the data is not being stored at a standard at a central place. It is distributed across the ecosystem. Wherever the hospitals are storing the data, it is their problem. All right. So of course there are ways by which you need to certify the hospital for something specific as this. Data is exchanged in a secure manner. This is encrypted data which is being sent across the system. So there is encryption and decryption algorithms which are very specifically designed for this. And I can point you to the specific websites where
Please.
they explain these details quite a lot.
Yeah, thanks. I'll turn over the mic to others.
Yeah. So can we get a copy of the presentation? Of course, most certainly. I mean, this is something. So that's a
Anish has
question.
got a question.
Yes.
Yeah. So Ambuj has a question about how do I put past data on this app? So you need a health repository, and one of the simplest and I would say something which does not cost you any money is the DigiLocker. I don't know whether you have been using DigiLocker. It can be used for a whole lot of data that you can store.
Yeah, I have it and I'm using it.
Yeah. So if you have a DigiLocker, then you can link your DigiLocker account to ABHA, and you will be able to store your data on the DigiLocker. Okay. How will current data get onto this app? My family doctor scribbles small notes on a small sheet of paper every time he sees me. Yeah. So if you have a copy of this, you can do it yourself. Eventually, one expects this system to have the data being sent as a electronic data. And once it is electronic, then of course it will be a lot less in terms of size than capturing an image or a PDF file. So that would be a lot simpler. But this is work in progress, and it's going to take a significant amount of time before the entire ecosystem does it the way it is expected.
So, Tatu, in my case, I mean, I just wanted to point out, I've
Yeah.
been through multiple procedures and primarily in one hospital, which is Max Healthcare.
Yeah.
And even though I've installed DigiLocker and I've installed the ABHA app and I have the number, it says no records found. So is
Yeah.
it that the hospital is not uploading anything or what is going on? So how do I get access to that?
Yeah, so basically, in this particular case, the hospital is not ready to transfer data. That's the
So
only
can I
reason
do
why.
something to make them do it?
As of now, no. As of now, there is no stick. There's only the carrots being shown. Okay. Eventually, it will happen. Eventually, in the sense that every hospital needs to renew their registration at a certain frequency. So, as and when they go for a renewal of their registration, the government is going to sit on their head and make sure that this happens.
Okay.
Yeah.
But as of now, you said only 500 institutions are using it now. Tatkar, I heard you say that.
No, it is a fairly large number. In fact, some of the largest numbers are in UP and Bihar, which is also very good because that's the place where you need it probably the most. And there are a very significant number of, as far as I know, the last number that I have seen was there were about 10 crore procedures for which data was exchanged.
But how many hospitals do you think? How many health entities would be there?
How many health entities? As of now, it is in the range of, say, somewhere around 50,000 or thereabouts totally. But we are still far away because you will eventually have more than about 8 to 10 lakh entities.
Yeah.
But okay, as I said, this is a work in progress. This is, and you can imagine the National Health Claims Exchange data being sent. We are the first to get authorized for doing this. So that's something which speaks volumes about this as well.
Okay.
Yeah. Satish, your question was about
two things.
Two things. One is to discuss the term family.
Yes, you know what happened? Today, my son and my daughter-in-law are living with me. So we are a family here. So as per this, if we are all registered, three of us as a family are covered for that 5 lakh and whatever, for the whole year, right? Tomorrow, when my son and his wife go and live somewhere else, they register themselves as a family. I remain here as my family. So aren't then both them covered under the scheme of 5 lakhs each?
So basically, I mean, you have an option available by which you can exit a family.
That's right. But then you register as a new family, right?
Yeah, you will register.
So the same three persons are now being covered with 10 lakhs with two different
correct.
families.
Yeah.
So what is the definition of a family? How are they controlling this?
So the definition of a family is what you put there under Ayushman Bharat app.
So ration card.
The three ABHA IDs.
Okay. So I mean, it is quite ambiguous to say because the same three persons who were earlier covered for 5 lakhs only, being one family. Now two separate families are there. The same three persons are there, but they are now covered for 5 lakh there and 5 lakh here. So 10 lakh.
See, With healthcare, this is always going to happen. Like, say, for example, there is a female who is currently part of one family. She gets married and goes to the other family. So you will have to transfer her out from here and transfer her in there.
No,
So,
that is there. But what I said was splitting of a family, which is three generations are living in one house. Let's say grandfather, the father, and the children. Today there are 7 of them covered under 5 lakhs only. But tomorrow, the moment the son and the children go out and the grandfather and the grandmother are still there, so they are two different families now.